Okay, look, it's 12 noon. That means it can only be one thing. This is our Power Hour Round Table on how do we regulate and improve quality. My name is John Wilkes. I have the privilege of being Chief Executive of the one and only Institute of Health and Social Care Management. And we're joined by various colleagues today who are going to help to discuss this important topic. I'm joined first of all by Vanda Carter, who's the Trust Practice Education Facilitator for Research, and she's also a professional nurse advocate at the Royal Wolverhampton NHS Trust up there in the Black Country. Lovely to have you with us, Vanda. We've also got at present Martin Lowthian, who's the Quality and Governance Lead for the Access Group, and we're looking forward to hearing more about what you do, Martin, within the Access Group. And we are awaiting Rick Canavan, who is UK Director for BA Healthcare, one of our corporate partners within the Institute. Rick may be a little bit delayed, but I'm sure he'll get here in the end. But we're just going to crack on because, well, how can I set the scene for this business around quality improvement? I guess we can just look at any number of the recent catastrophes to have befallen the NHS, be that maternity care, be that young children falling victim to sepsis when they really should have been picked up earlier, be that issues with, workforce, and be that issues with stuff like virtual wards coming in because we don't appear to have enough people to look after and discharge people adequately from the hospital in the first place. I mean, can we start, Martin and Vanda? I'm anxious to make this as positive as we possibly can today, but my view is that we may be in a situation where the NHS, and to a certain degree social care, is institutionally unsafe at present because we can't staff it properly. We don't have a culture of trust across the organisations where people feel able to speak up and really explain their circumstances and their experiences. And overall, this is this umbrella of regulatory activity that appears to me to suffocate the opportunity for us to actually be more forthcoming and ready to confront safety issues more fully. So look, that's my starter for 10, and I apologise, Rick's just missed me going off down the black run piece that I've selected for this.
Sorry, I'm late, John.
It's all right, Rick. Nice to see you. But would any of you like to comment here? Vanda, you're grimacing because I suspect you're thinking, well, he might be right, but I can't possibly say that he's bang on here. But what do you think? Where do you stand on this? Do we have a culture at the moment where we are set up to fail in terms of patient safety?
I think you're most probably right, John. But speaking for my organisation, with all the things which have been going on just lately and in the news, we're just as appalled and shocked as any member of the public are. And I can assure you that we, as an organisation, do take things seriously. So, for example, the Lucy Letby case, our chief executive put out a statement within 24 hours to all staff to reassure and to sort of articulate his abhorrence about it all. So you've got some very good people within the NHS, and I think we are there to help people, and we're there because we want to be there. We have a vocation to help people, and I still strongly believe in that. So yeah, things are very tough at the moment. We have a lot of work to do. We have a lot of confidence to build, but I essentially believe that the NHS is strong. It has some very good people working within it, and we can improve things.
Let me push you a little bit. Is it? And I'm not referring to your trust here.
Of course, yes.
Overall, do you feel that the NHS is safe?
Probably not from a collective point of view. Probably not. No, I'm speaking from my own opinion. I'm not representing.
No, I get that completely, Vanda, and we value that. You know, we're huge fans of your trust and all the others with whom we associate. And you're right, there are great people working within the NHS, vocationally driven to deliver brilliant care. My anxiety is not about the individual people. It's about the structure that we have created that denies them the opportunity to talk intelligently and honestly about safety within the therapeutic area that they are responsible for. I'm looking today, Roy Lilly's in his blog this morning has flagged up a link whereby there are now reckoned to be 126 organisations around the NHS that exert some kind of regulatory influence. 126 organisations. I mean, how can anybody make progress in terms of intelligent, consistent safety improvements with 126 different organisations who are inconsistent with their own approaches, which are manifestly fragmented in terms of their ability to talk to one another? But Martin, your thoughts initially. Where are you coming from?
Unfortunately, I have to agree with you and Vanda, which is that I think there are real safety issues around recruitment. I think there is a real challenge around the management of safety, the learning from safety incidents. I think having worked in the NHS for 14 years, and I've worked in social care for 13 years, I think the NHS has had a more joined up and mature approach to it than social care has historically, because of the infrastructure that's there. And I think there is more direction nationally around the National Health Service. I've predominantly worked in acute hospitals, teaching hospitals over the years. So I think there is a more joined up approach. But that said, I think the impact that the media has and these significant incidents have, unfortunately, beat down those great people that we've got working in the NHS and in social care, and it makes it a less attractive place to work and stay. So I think that's one of the challenges, and I think that's one of the big workforce challenges we have, that because of the high profile incidents that we have had and the fact that they happen every now and then, it's not just that sort of never event that we used to talk about in the NHS, that they happen every now and then now. People just think, I don't really want to go to that environment. That doesn't feel like a career I wish to pursue.
Well, if we were improving as a result of the mistakes that we make, and we will make mistakes.
Absolutely.
If we were improving as a result of those mistakes, because there was an open and honest yearning to improve and tell the truth about what has happened, I'd be surprised if we were having this conversation now.
Absolutely.
And the problem is that the superstructure that surrounds health and social care denies us, I suspect, the opportunity to have open and honest conversations with each other about improvement processes and such like, and learning from the mistakes that we make. Absolutely. Rick, lovely to have you with us. Any observations from you in this regard?
Yeah, I mean, just for the benefit of those on the call, I'm the UK director of an international recruitment business, and we work with health and social care providers primarily in the UK. I mean, certainly within that space, within the international recruitment space, one thing which has really shocked me in the last couple of years is the willingness of a lot of providers, and I think this is perhaps more private providers or sort of non-NHS providers, is the willingness to take on international recruits who have very limited experience, whose language skills, at least relative to people that we would place, are not adequate, and who have very, very little experience. And I think a number of providers are now seeing just where that can lead, and partly in terms of retention, partly in terms of service quality, but also worryingly in terms of safety. It is really shocking, to see the CVs, of people that some providers are employing. I mean, they're simply not people who we would, even consider putting forward for a job. And the reason for this has been, of course, essentially once a provider has a UK VI sponsor license, that is then public domain. So they are deluged by CVs. And I think what happens is you go from a situation where you could be advertising a role in the UK, getting almost no interest, to overnight having people beating down your door asking for a job. It seems like, bonanza. This is great. This is the end of workforce problems in this organization. And there isn't a pause. But I think we're now in a situation where you've actually got a significant number of people working, particularly in adult social care, who are really not necessarily the right fit for it. And I think this is just starting to become apparent. I don't pretend that there's a solution, but I think that this is a real issue. I couldn't comment, on the NHS, and I don't know, Vanda, if perhaps you have some thoughts on this, that'd be really interesting. But certainly from the international recruitment space, that's certainly something that we see and feel, and we have quite not infrequent discussions with providers who perhaps come to us through through various organisations for advice. It's really quite worrying, and very often they're very straightforward about what they've done, about the people they've got, and they say, well, what can we do? And the answer is, well, it's an extremely difficult situation to remedy.
Okay, thank you, Rick. I'm going to come back to Vanda in a minute or two. I don't want to, if possible, make this hour all about let's identify the problems. I'd much rather we collectively, and with our audience, we've got some really good people, intelligent people in the audience as well, who know their way around QI and so on. Where should we start if we're in any kind of an organization delivering health and social care, and we're serious about quality improvement? Vanda, where should we start?
I think with the workforce itself, yes, we do have problems, and I totally concur with Rick. The caliber of people applying for jobs, and perhaps people are in jobs who wouldn't necessarily 10 years ago be shortlisted to that job at the moment. That's the nature of the beast, unfortunately. But I think the answer is with the people who work within the organisation.
All right, so
sure.
let me help you here, if I may, because I might question the idea that we start with the workforce. I might say, look, if we're serious about improving our, this very topical thing, given the experience of Martha Mills recently, how about we look at how we deal with sepsis within an organization? And my view is we don't start with the workforce. They're second on the list. We actually start probably with patient experiences, and we audit recent patients who've come into the unit with symptoms of sepsis and so on. And we ask ourselves, are we properly set up to be able to identify sepsis such that every member of staff is properly trained and is able to spot underlying symptoms? But most importantly of all, do the patients feel listened to? Do they feel that their concerns are being taken seriously? And do we have an appropriate process to fast track people if we detect there may be any kind of risk? So that's kind of what I was looking for. Okay. I don't doubt the fact that you're right about workforce, and it may well be that one of the things is that from a workforce perspective, certain organizations are over trading in terms of, they're understaffed versus where they would expect to be, and they struggle therefore to be able to find enough people to deal in a compassionate and effective manner with people presenting. But that shouldn't stop us thinking that, we've got Kunle Thomas here in the audience today, who's just written the book on patient advocacy. Should we just basically condition ourselves to be saying, with everything that we look at from a QI perspective, let's start from the patient and work backwards?
I would also put in, let's start with the evidence base, John. So obviously I'm a researcher, I have a research background. So yeah, you're quite right. The evidence base is very important. So with the sepsis scenario, what is the evidence base, and build from there really. So we're working in an environment, the nurses are so stretched, they're relying on the equipment that they use, and so very much the training is based on sort of checking patients. So when I was training, it was about looking at the patient. Now it's about looking at the monitor. So that's quite disappointing, really. But that's where we are.
Okay. That's fine. Thank you. I can see Anna Harding's got her hand up. Anna, would you like to come in quickly with a question or an observation?
Yeah, thank you. So I work for NHS Workforce as well. And what I would say from a quality improvement perspective is that identifying the primary drivers, it's multifaceted. So the sepsis example that you gave, the patient is as much important as the evidence that Vanda's suggesting, because without multiple primary drivers drive the overall quality improvement from that. You can't identify the patient without the evidence. The evidence will also generate patient care. So I think
but are we set up at the moment to actually receive patient feedback in an intelligent, effective and honest manner?
So I would push that back to say that would be part of your analysis, I think. So that would be another primary driver, because some organisations may be, some organisations may not be. So that would become part as what are your primary drivers, what are your risks, and where are your deficiencies? And then when you'd analysed all of those together, then you would be able to move forward to say, right, what is actually now our priority?
All right, well, we'll take that. Martin, do you have a view in this regard? And then Kunle, I'd love to bring you in, if you wouldn't mind, my friend, if you'd like to come in when Martin's made his observation. Thank you.
Yeah, I do, John. Thank you. I spent a lot of time when I was working in the NHS doing a lot of work around risk management. And the risk management was around all facets of risk. So what are the services we should provide as a provider, an acute hospital? If I'm a specialist acute hospital, what is my cohort of patients? Who are the right patients for me to see and treat? Have I then got the right skills? So if we look at the risk or the opportunity, who am I meant to be treating as an acute hospital? Do I then have the skills, the competency, and things like Dr. Foster's hard evidence of what were my outcomes compared to other outcomes? If I'm the Royal Brompton or the Royal Marsden, for example, I'm not going to expect to be on the normal line compared to hospitals that don't treat the same complexity of cases. But actually, am I where I would expect be? I think there are. I completely agree with Vanda. There's a lot of hard evidence that should support you. But if I give one example of a piece of work I did when I was at the Royal Marsden, a big piece of work looking at ambulatory chemotherapy a number of years ago was a lot about the patient voice and the family voice, because we had our own objectives for what ambulatory chemotherapy would do for patients and their families. We needed to validate whether we were actually delivering against that, and that was living better by living at home rather than constantly being in hospital having their chemotherapy. So a lot of our validation through the research to say, did ambulatory chemotherapy as a treatment work better than coming into hospital, was around the outcome and the feedback from patients. So I think there are pockets of excellence where trusts and organisations do that. I think there are other organisations who are set up to deliver services that they are not equipped to deliver. And when I've done recovery and risk consultancy in my past in hospitals, often that's where they were trying to deliver services that, if they were brutally honest, that actually they weren't skilled or effective at delivering. And for me, my view on that, if I had a position of authority, I would say, right, that hospital does not deliver this, this, and this, but actually they can focus on these specialties. We take those three things and we move it from that trust to that trust.
So what I'm reading here is that you're using data to spot outliers, and then you're going in and you'd be, if it was you or NHS England or a CSU, for example, you'd be going in based on the outlier evidence, the data,
Yes.
And then you do an audit of what's taking place or what's not taking place. That's the bit that I'm worried about. That when we start to audit, that it's very difficult for people to speak up and really tell how it really is within their unit, because they fear the consequence of speaking the truth. They fear the consequence in terms of, I'll call it overtrading, where they know there's not enough staff on a ward or a unit to be able to do what they've signed up to deliver, but people are not easily going to be able to speak up and say there's just a consistent problem here, because they fear the consequence of it.
Yes.
When we're doing an audit with patients, they fear the consequence of speaking up directly, because funny enough, they're under treatment at the moment and they don't want to be antagonizing the very organization that is responsible for help making them well again. So we're kind of already conspiring against ourselves in terms of being able to speak up and be absolutely open and honest about the experiences and the deficiencies that we're experiencing on a daily basis.
Yeah.
Rick, do you think that's a fair observation? And I'm happy we bring in social care into this. You know, this is not a discussion purely based on NHS.
No, I absolutely. You know, and I listening to you talk, and when you talked about workforce, Vanda, my initial thought was you're absolutely right, but I think in a way you can throw all of the human resource into it that you want. And I've seen this done, you know, with providers who will perhaps, you know, take on, you know, huge numbers of people, but the needle on quality can then not move. So I think that, yeah, without that focus primarily, the people aren't necessarily the answer. I think it's very easy for, you know, certainly for providers in the private sector and adult social care sector to zero in on workforce. But I think that perhaps ignores other structural problems and other cultural problems in organizations, because it's also, in a sense, it's the hardest thing to solve, but it's sometimes, like with international recruitment, be the easiest thing to solve as well. You know, once you're set up to do it, you know, and you can zero in, and it's a very simple problem in a way as well. You know, the workforce problem is we don't have enough people. The solution is we need more people. You know, so it's very binary. It can be very easy to sell that as a solution in an organization, easy to get funding for it and things like that. You know, there isn't the knottiness that a lot of you know, clinical quality problems might have. And so, you know, there is that, you know, often human default towards slightly lazy thinking, and right, well, that's the easy problem, let's solve that. So I think it very often becomes the absolute priority, and once everybody is bought into it and piled on, it's the thing which we've all agreed tacitly is the thing that's going to solve everything. But I think it, you know, it's very often part of the solution, but without a strategy, an evidence-based strategy to tackle a problem, it isn't the solution. You know, so I think workforce is always going to be a very important part of it. And of course, it isn't just about numbers. Obviously, we come at this from a recruitment perspective, and I tend to see it in terms of more people. But of course, you know, it's more skills, it's more communication, it's better integration of people in teams and things as well. But yeah, yeah, that's a really difficult one, I think. But I think workforce absolutely has a role in this, but it really is not the sort of single point of truth as an answer.
I was sort of alluding more about knowledge and know-how rather than the numbers, and that we have the capability to answer our own questions and to solve our own problems, perhaps. I think the issues that we do have, that we always go with the same approach rather than trying new things. So I've got some interesting papers I was discussing before we came on air to share with you. Mary Dixon Woods is a guru around this area. So I've got a very good paper that she wrote with Peter Provenost in 2016, that patient safety and the problem of too many hands. So in short, that it's the ebb and flow it's counterproductive. And I've written a few notes here. Failures of coordination and integration in the healthcare also contribute to the current arms race of performance and quality metrics, and the confusion and distraction it creates, and the diversion of resources into improvement efforts that are given ineffective and that are often ineffective and inefficient. So I'll certainly share those with the audience, but often I think we're counterproductive in these things, that we're very knee-jerk reactive rather than looking at a systems approach. And I'm very much favouring systems approach to safety and quality, and we solve one issue and then go on to the next thing. We don't learn as an organisation.
Well, part of that may be that we've got this wet blanket thrown over all of us, and I'm going to name them. We've got the Care Quality Commission, and we know, you go around various organisations, and the purpose of the organisation, the principal objective of the organisation, I've seen it at first hand. It's stated on walls and so on and on. Posters around the place is to get an outstanding CQC
at any cost.
Report. That's what people are expected to get out from under the duvet on a wet Wednesday morning in February and come to work in pursuit of. Well, it don't work.
No.
I mean, worse still, if that's the overall objective of any organisation, and you find fault within your own organisation, you dare not speak up about that, because the consequences for your organisation's ability to then hit the outstanding mark are compromised. So somehow this negative deviance approach, as I'll call it, we're just working against ourselves all of the time, when people who are perfectly knowledgeable, vocationally driven, empathetic to the needs of the patient, and desperate to do a super duper job, all the sort of forces within their organisation and the wider NHS CQC superstructure are saying, yeah, but don't pick your moment when you're going to speak up, and be careful about it. We can have all the guardians that we like, about speaking up and so on. But we have to break this cycle of regulation and inspection and consequence that stems from that. In my view, if we're serious about making genuine improvements in quality. But that's just my view. Kunle, Thomas, would you mind joining us in this panel? You can perhaps explain to everybody about the book you've just written, that we were privileged to write the foreword for. You've heard what I've been saying. You've heard what Martin and Vanda and Rick have been saying. Have you heard anything so far that reassures you that the nettle is being grasped?
Yes, thank you so much, John. I appreciate giving me the opportunity to speak. Right. So my name is Kunle Thomas, and I've recently written their patient practical guide to patient experience. So basically, I work as permanent staff for a number of NHS trusts, but I've been working for some time now as a interim contractor to the NHS and trainer, essentially in the areas of patient experience and engagement, and some areas around quality as well. So basically, I think I quite agree with most of the comments that's already been made. For example, Vanda was just talking about quality metrics now, and Rick was talking about the different parameters that we need to look at. So yes, there isn't any one bullet, one point takes care of everything. Staffing, yes, obviously, is a very key issue. When there's a very common statement where we make in patient experience that happy staff equals happy patients. So in other words, if staff are overworked because there is a major understaffing, that means a few that are working are doing much more than they should be doing. They become impatient, they're likely to miss things, They're likely to kind of probably be snappy at times when, you know, working for so many hours, doing maybe the work of 2-3 people. So they are not at their best. And so mistakes starts to happen. And so that's one issue. So understanding is that communication, as we've also had, is a
kind of like, how easy is it for somebody who knows that they're working on a ward or a unit that is systematically understaffed? How easy is it for them to say this is now starting to compromise patient safety?
Yeah, that's an interesting point. So basically, from my experience, and I've worked across, you know, from ambulance service to mental health to acute to, I've moved around, which is the benefit of working as an interim after I left permanent role. And I can say, yes, there is, you know, for most people, I think for most staff, they, you know, mention this to their ward manager, who will normally know anyway, but they, you know, they will raise that. But how well or how willing they are to push it and go to the highest level to complain and to say we're not happy with this, most people don't go, you know, to that extent. Most staff will just probably mention it to their ward manager to say, you know, as you know, I mean, we need X number of staff to do this, to do that. And she'll probably say, yeah, we are trying to get the funding, blah, blah, blah. And that's where it ends most of the time.
Why don't they push it?
Well, I guess part of the issue could very likely be that people don't want to put their heads above the parapet too much, because they're thinking, well, because obviously everybody at the end of the day, they don't want to be seen as being too antagonistic. Some do, but there are very, very few people that are ready to challenge the system. Most people will basically speak with the lowest tone of voice. I mean, they will whisper the issue. That's the way I'll put it. They whisper the concerns and then they keep quiet to say, I've done my bit. You know,
so basically the system conditions people to put up and shut up.
To some
I am
extent,
going to offer an alternative to that.
To some extent, but as I said, it's a mixed bag. There are a few people who will be very, very challenging and say, look, this is not right, we need to sort this out. But most people it's just not in nature, most people to do that, because they're protective of their jobs, they're thinking they don't want to be seen as troublemakers and stuff like that. The same thing goes even with patients, right? And so basically, you were talking about you know, the data and how well we use the data. So because most of everything, virtually every challenge that the NHS or even in the private sector are facing today, right? But let's for now focus on the NHS. Most of the issues we're having, there is data there that could enable us to fix the problem or at least understand what the issues are, right? But the collection or analysis of data is one thing. The implementation and actually say, okay, the data has told us X, Y, Z, actually taking that to the next level to complete the cycle and actually action those things is a completely different thing. And from my experience, right, we don't often get that last bit right. Right, so we do. There's the data. There is data overload, if I can put it that way. We have loads of data, but when it comes to analysis, the number drops. Right, so proper analysis of that data to really figure out what is this data telling us. That number drops from those, you know, considering the level of data collected. Now, when you now move it forward again to say, okay, we've analyzed it. For those who've done a great job in analyzing the data, how many are actually implementing, you know, or everything what the data is showing that needs to be done? That number again drops really, really low. We end up with a very small number. So I think that's the issue: the standardization and you know, making it the norm for us to go through those stages, not just collect data alone, but actually take it to the logical conclusion. Doesn't always happen. And
thank you.
Someone mentioned whistleblowing earlier on. I was listening to a program recently interviewing, I think on BBC News. They brought in a few experts and we're talking about this. And we assume there is that protection for whistleblowers, but as some experts were saying, actually that protection is not actually a proper protection. It's not, because a lot of that's another issue. Anyway.
I don't particularly want to go down the whistleblowing route. That is a completely different. Well, it's an additional topic that contributes to this. We haven't got time to hit it today.
Yeah, but there's a link, because when people do see and notice things that are not going right, again, that is a key component of how do you make sure that you have the quality, because you have, we gather information through different sources. One source is the data, one source talking to patients, so many different sources that we use in gathering data. And one of those sources actually is through whistleblowing. But as we said, we won't go into that, but it is part of the problem.
Thank you, Kunle. We have to move along. I can see Anna's got her hand up. Anna, did you want to make another point?
Yeah, I did actually. So I'm going to offer the alternative to that, in that our data has changed. So in the last 5 years, we've had a change of culture and leadership. And going back from the NHS where I am, actually the profile of most NHS nursing staff, which is your biggest body, is what we call a green insight, which is culturally a person who doesn't normally and doesn't have a tendency to speak up. So now that we understand what our profiles are like more, we have a system that operates on a red, yellow, top-down approach with a workforce in large number that's green. It's about changing the system. I don't believe that there's anything wrong with measuring. Going to outstanding tells the patient where that organisation sees itself and what their experience might be. The same in schooling. We all look up at the Ofsted report before we put our darling child into that school. The way we measure may now need to be changed, but I don't see that there's anything wrong with having that measure. It's about understanding what our workforce is. And now that our data has changed in the last 5 years, that culturally we make that change, and that starts with us. So rather than top down, we need to go bottom up. I've been a whistleblower. The 3 trusts that I've worked for were extremely supportive to me. There was great structures in place and there was changes made, and I was well respected for whistleblowing. So I always advocate that. So I believe that there's a positive side to a negative spin, and actually our mindset is to change discussion positively to say this is where we are, and now how are we going to build rather than destroy what has been before. It was relevant before, it may not be now.
We're big fans of that. I like the sound of that, Anna, and I'm going to come on to that very theme in a minute or two. So thank you. I can see we've got Tony Fenn. Tony, you've got an observation to make.
As you will expect, I suspect most people will have great difficulty taking on board what I'm going to say. We're missing the whole point. Quality is not something imposed from outside. It is something that is built up from inside on an ongoing basis, and it never stops, which means you need appropriate systems for monitoring, audit, assessment, implementation, and it's a continuing virtuous circle. You don't get it by inspection, you don't get it by regulation. They're a total waste of time and waste of money. We went into...
My mystery is that you think that anybody's going to disagree with what you just said. Because,
well, expanding on that, in every healthcare organization we assessed, and I'm talking about ISO quality management systems assessment, ISO 9001, every single healthcare organization around the world said the biggest problem group is the doctors. They are resistant all the time to everything. So that is something that needs to be taken on board. Secondly,
yeah, and we need to be fairly quick. I'm going to slightly hurry you along.
Okay.
Go ahead.
If you don't have safe staffing levels, you have to concentrate the staff. So you have to close hospitals. And people immediately come back and say, but you can't reduce beds. I'm not talking about reducing beds. I'm talking about closing sites and increasing capacity elsewhere so that you can develop the safe staffing that allows you to have 5 people covering every post, because that is what you need as a minimum to be able to have safe staffing levels for a single post, 24 hours a day, 365 days of a year. And our ITU manager, when we wanted to open a bed, insisted on 8 members of staff being funded, or she would not allow us to open the bed. The space was available, the equipment was available, but we had to fund 8 members of staff for that bed. And I can tell you what they all were. 5.
Oh, no, it's fine. It's fine. We don't need to.
So workforce is important.
So what it comes down to,
but you don't impose it, and it has to be developed from the bottom upwards.
Well, we like that. We'll buy that any day of the week. I'm bang with you, and you've got a lot of support in the chat as well in that regard. So look, let's try to help people who are on the in the audience today to say, all right, if you're interested in how you might build quality within your organization, how do we do that in an intelligent and effective manner? Would anybody, Martin or Rick or Vanda, would you like to offer some tips about where you might start? Martin.
Yeah, I'm happy to start. I think this is something that, I agree with a lot of what Tony said there. And I think for me, one of the big things is being systematic about it, absolutely not being obsessed about the regulator, being obsessed about what are our objectives as if we're an acute hospital, if we're a social care provider, what are our objectives? How do we deliver our objectives? Given the resources we have, the skills we have, the competency we have, what can we genuinely deliver? What can't we genuinely deliver?
Who leads that, Martin?
That's got to be led for me by the senior management team. I used to do board assurance workshops with acute trusts, but what you do is you do the top down. So from the board and the strategy level, what are we going to deliver? But you also join it up with the bottom up. These are the risks, these are the challenges we're facing. And also here's the evidence of quality, lack of quality, challenges. You validate where your risk levels genuinely are from the bottom up and the top down. So for me, it's your effective risk management delivers effective quality improvement.
So that's data led, and then you are
experience.
But you are empowering the front line, if I can call them that.
Absolutely. And your patients.
But you are empowering your front line people to access that data and see the results of analysis.
Absolutely.
And then you're asking them to come up with their own ideas about how might this be improved.
Absolutely.
And then you're asking the more senior people to take on board those recommendations and fund them properly such that improvements can be legitimized.
Absolutely. And
Is that about right?
And be courageous, John, and say which are the things we're not going to do.
All right. So I like that. Vanda, would you like to, if you were going to start, where would you begin a QI approach that might actually, successfully engage people within your organization?
Looking at my organization has been very resourceful and put training packages together for all staff. So they've gone on providing the fundamentals, the philosophy around CQI. So a lot of resources have been put into
on data and so on, and
the tools. So understanding what is QI and providing our staff, our workforce, with the tools to understand what it is and the power that they have within them to actually look at their own services and plan ahead and use the tools given within the training. So a lot of resources gone into my organisation to do that.
Is it universal, Vanda? Does everybody get that training?
Yeah, it is multidisciplinary. Everybody's been offered it. There's a fundamental course, which is 1 day, and then there's a QSAR course, which is a 5-day course, which is offering tools and resources so people are equipped with planning and doing their own CQI project within their own areas. So that's how it works at my organisation, providing them with the information, what is quality, what are the tools available to you, and how it can be done.
I'm just interested here. Is that a course that is consistent across the NHS, or is it something that
it's been rolled out by HEE, so it's an NHS-led course. It's a great big book which is available, full of resources. Not so good for saving the planet, but so it is available, and it is consistently offered to all NHS organisations.
All right. So there's a thought. Rick, your thoughts on this? Because I'm going to ask in a minute.
Very much in line, I think, with Martin's. I think the idea that quality is very nuanced and multi-layered. But I think that the thing which you said, Martin, which really resonated with me was really around the involvement of frontline staff, but also service users as well, in determining what does quality mean in general, but also what does quality mean in a more localized way. And that really could be, be quite hyper localized. Now, I appreciate that obviously there is a time cost and a money cost and all kinds of issues in determining, what quality means for, for a patient or service user in any given context. But I think it can be very easy under the current way that we look at quality and quality improvement to really marginalize that. And I know people would say, well, but of course we talk to patients and service users about it, but my feeling is that very often those conversations are not really conversations that yield learning points. I think they're not always, they're not always listening conversations in a sense. And when you've got a machine that is not interested, or perhaps not as interested as it should be in, looking at what does quality mean in a particular context, it's very easy for that input to be overlooked. So I think, very much as you were suggesting, Martin, I think it's looking at what does it mean on the front line rather than at this sort of meta level almost.
Thank you, Rick. All right, so I've got a big question. I'm kind of with Tony Fenn. I don't often say this. He's a fine man, but on this, I think he's spot on. You build quality into organizations, and it's a continuous progress where you are constantly encouraging your people and the people who you serve to help you to improve the quality, and you build that into the process through systems improvement and all the rest of it. So why have we got a superstructure that spends, I think I'm right in saying, about £228 million a year that is designed to inspect its way to quality improvement? You can read any management textbook worth its salt, and it says inspection doesn't work as a means of building quality. How do we break the cycle? Because no politician at the moment is prepared to even entertain the idea of doing things differently, be it education, health, policing, whatever else it may be. We've surrounded every single state organization that we hold dear with this regulatory inspection-based framework that we know doesn't deliver quality improvement. If it did, we wouldn't be endlessly having the terrible situations that afflict us and that we're all conscious of. How do we break that cycle? Martin, would you like to hazard an opinion?
Yes.
£227 million is a lot of money to spend.
It's a heck of a lot of money. It really is. And I think the problem is it's almost the culture and the fear of the regulator that has driven them to do what I've described as bayoneting the wounded during and post-COVID. There's a negative rather than a quality improvement drive. They're fearful of their own reputation, and dreadful things happen. They can't prevent everything, but actually there ought to be this systematic approach. For me, rather than having them going out and inspecting, actually, if the resources were rather different, actually organisations ought to be better equipped to do that systematic quality monitoring, quality improvement themselves. In Scotland, with Care Inspectorate Scotland, you submit a self-assessment which says how you're performing. Well, for me, why wouldn't CQC look at a model, or the government look at a model, where actually with fewer people in CQC, which is being paid for by NHS and social care organisations through fees, actually let's take less money out of the coffers of those provider businesses and allow them to invest that in their internal quality systems. And then through that, they can take that systematic evidence-based approach internally, share that information with a lovely provider portal that should be available nationally and not regionally, spread out over several months, perhaps, if we believe the webinar. So for me, enabling providers to be their own conscience somewhat is a good step forward, but then having an evidence base where they're submitting to an overseeing organisation, whether that's CQC, whether that's an outsourced organisation, a bit like we've got, Ofcom and all the other lovely ones, should it be CQC? What's their reason?
I'm quite happy to spend £227 improving quality, £227 million improving quality. That sounds like a fantastic investment to me. And I'd use the good people at the CQC just in a different way, basically.
Absolutely agree with you.
All right, Vanda, your thoughts on this? I think we need to do things differently if we're going to sustain our healthcare services. So using expertise like peer review is a very good process to actually raising the quality. We do it all the time in research, and also user involvement as well is a big quality measure. So asking our users about the quality of services would be something we should consider. Decision-making councils as well, run by staff, are starting to sort of pick up momentum. So again, it's very much peer driven and user driven. So maybe we should be using those.
I love the idea. I really like that, and I love the idea. It's something we talk about in some of the QI training that we deliver, of asking people who may be in supervisory roles to ask their teams, what does quality look, feel, and sound like where we are? So ignore the big, high up objective of the organization and just say to your own small team, let's agree what quality looks, feels, and sounds like here in our organization, so we can look people in the eye at the end of a working shift and say, yes, we did, or no, we didn't. And if we know we didn't, then let's figure out why and be empowered to do something about it. And
a systems approach, John. That's what we need to
start to make some progress.
Yeah.
To say nothing, show people what great looks like, and then help them to achieve it. Positive deviance, as opposed to the other way around, find fault and then beat people up until they improve. But that's another one. And I am going to come back to Tony Fenn, who's being very patient. He's got his hand up, but I'm going to ask Rick, first of all, your observations on that first.
Yeah, I mean, Martin and Vanda, you're obviously both much closer and better qualified to comment on this than I am. But I think that one of the really big issues around these, these very frankly glib standards of outstanding, etc., is that they obviously become organization and institutional goals that trump anything else. But in doing so, they also, I think, very often sort of strip personal responsibility or give people a sense that they're not personally responsible, because they're either unobtainable or they don't really mean anything in reality, but that the whole organization is striving for it. So what is your role in that? What is your role in obtaining the unobtainable, or in obtaining the not really comprehensible? Well, it's nothing. And so, your role in the organization, I think, is devalued by them. So I think, that you have to move away from that and move away to a more localized idea of quality that rebuilds some sense of having personal responsibility, for quality. But I say that very much as an outsider on sort of health and social care organizations.
That's the beauty, but that's why you can say it, and that's why we value it. That's why I value Kunle's involvement. He speaks truth, because he's got flesh in the game from the patient's perspective, but he can say these things without fear of immediate recourse and being slapped down. But Tony, you've got your hand up. You've been very patient. Just come in very quickly, if you don't mind. We've not got very long left.
Assessing healthcare organisations is a continuous process and it does require peer reviewers of appropriate experience and seniority. The organisation I was working with had between 8 and 10 full-time employees, and it had a list of about 500 potential peer reviewers. And we worked with between 30 and 70 healthcare organisations around the world on a continuing process. It cost less than £2 million a year.
There you go. I'll mentor that, Tony.
And example, we would feed back to the board, you have a cardiologist who does not communicate with his nursing staff and has his own patient protocols that he does not share. He may be an appropriate clinical leader, but he should no way be a managerial lead. He's dangerous. On the other hand, you go into an organisation that's a continuing care institution that have had an individual with untreated hydrocephalus since they were very young, and they've been looking after him for 32 years, and he can only be managed on one side or the other. In that whole 32 years, there has never been a single skin ulcer anywhere on his body. That tells you about nursing care, training, handover, supervision, etc., etc., etc. We didn't really need to ask much more about that organisation when we found out about that.
Yeah, but that's the kind of point I'm making, positive deviance. So whatever they're doing is brilliant. How can we help other people to achieve that rather than punishing them for not doing so? That's kind of the point I'm arriving at. All right, thank you, Tony. Always good to hear from you, and thank you for joining in today. Well, look, we're just about out of time. I'm just going to give each of the panelists today 1 minute just to sum up what they would like to encourage audience members to think about if they're serious about developing QI and quality guarantees. Any volunteers? Who wants to go first? All right, I'll just have to choose. Martin, go on, you've got the gig.
Yeah, happy to go for it. Yeah, I think what we've all said today is about that systematic quality focus. Why are we here? Whatever organisation I'm in, if I'm an acute hospital, if I'm a GP, if I'm a social care provider, the person I should be focusing on is the person we're treating, supporting. How do I do that effectively? Have I got the right processes, quality, skills? Am I achieving the right outcomes? Am I learning from those? Learning from great outcomes as well, learning from negative outcomes, learning from compliments, not just complaints. Regulators tend to focus on how many complaints have you had? Actually, I've had 3, but I've had 97 or I've had 300 compliments. Focus on all dimensions of quality. That's feedback in particular from the people you support, patients, residents, etc., but also the voice of your team. Ensure your team is heard. Tell them what you've done about what they've told you. I think that's essential.
And I love what Anna's written in the or has repeated in the chat. She said, teams love quality when they're empowered. Talk positively. Negatives
Absolutely.
can be talked positively. That's a great line, Anna. I really like that. Thank you.
And own things that haven't gone well, and then say what you're going to do about it.
Lovely. All right. Thank you very much. Rick, would you like to go next?
Yeah, thanks, John. I think all I would say, I mean, I hope it's sort of come across in what I've said previously, but I think what I would say is really just to have the courage to try to push a little bit against those, institutional pressures around those, quite nebulous ideas of quality, and just have the courage to speak up about, quality at a local level, within a group and within a team. And I know that requires, the sort of time and headspace that is not always available, because in a way what I'm saying is, right, well, you're going to have to work on that CQC quality track, but also then develop another quality track, and implement that locally. But I think the main thing that's missing there is very often the courage to do it, in a sense of, well, what's the point in it? But I think there is enormous point in it, in terms of a, sort of a patient or resident experience. That will very often be the quality that they experience. And obviously that's only only one facet of it, but in terms of the difference that you would make individually, I think there is enormous potential in that.
All right, thank you. So that's something about well led from the top in terms of, chief executives, business owners actually empowering and believing in the value of investing in quality systems and quality processes and building quality from within. Thank you. Vanda, over to you.
Unmute myself. So very much agree with other members of the panel there. Working together, engage your team. We are a team. Don't work in silos. Listen, be solution focused, be kind and caring, and consult your evidence base. Do your research. Ask other people. The Academy of Fab stuff or a fabulous, it's what it is on the tin really. So go to people and places who have done it before, don't reinvent the wheel. So there are lots of people with lots of experience out there. Use that valuable resource. Be bold and innovative. Plan ahead. And that's all I've got to say really. There's lots of resources out there.
No, perfectly done. Thank you very much, Vanda. Well, look, we're bang on the time. Look at that. Bang on time. Tell you what, I've enjoyed that. Thank you to the panel, Martin, Rick and Vanda. Thank you for those of you who came and spoke as well and asked questions and gave opinions. Kunle, Anna, Tony in particular, and those of you who contributed to the chat. Really appreciate it. Look, this is a topic we need to return to. It's a topic that I would like the Institute to really get into the guts of and figure out how we can positively help organizations, big and small, to actually make improvements and be proud of their approach to quality. So thank you very much, all of you, for listening in. If we're a little bit controversial at sometimes today, well, hell, if you can't express an opinion, then there's not much point in the opinion, is there? There we are. All right. Thanks very much indeed, everybody. Have a
Thank you. Thank you all.
Make sure that you look, I'm not even wearing a tie today, but probably the first time on one of our broadcasts, not wearing a tie in this mini heat wave. But there we are. Enjoy it. And whoever you're cheering for in the Rugby World Cup over the weekend, I hope they win. Thank you. Bye-bye.